We've trained a whole bunch of new nurses over the last 5 years. A lot of our senior nurses have gone into retirement or transitioned into different careers. The struggle we have right now is making sure that the nurses that are new to our profession in the first 3 years, that they feel supported, that they stay engaged, and they keep their jobs.
Welcome to the Business of Healthcare podcast. From the Center for Healthcare Leadership and Management at the University of Texas at Dallas, Naveen Jindal School of Management. Here at UT Dallas, we bring together business heads and other thought leaders to help navigate the challenges of our rapidly changing, increasingly complex healthcare ecosystem. I'm your host, Professor Dan Karnuta, Director of the UT Dallas Professional Program in Healthcare Management. Be sure to subscribe on Apple Podcasts, Spotify, or your favorite podcasting app to ensure you don't miss any future episodes. You can also join us online at businessofhealthcarepodcast.com. Our previous episode focused on the people and process elements of implementing an artificial intelligence solution in a healthcare setting. In today's episode, we're going to continue that theme, but bring it down to the frontline operating level by discussing how technology is used to improve healthcare workflow at the heart of delivery, the nursing. And our guest for this episode is an expert at that. Dr. Teresa McDonnell is Senior Vice President and Chief Nursing Officer at Duke University Health System. She's also Vice Dean for Clinical Affairs and Innovation at Duke University's School of Nursing, and she's a practicing nurse practitioner specializing in gastrointestinal oncology. Welcome to the Business of Healthcare podcast, Dr. McDonnell.
Thank you so much, Dan. It's a pleasure to be here.
Well, let's first, I like my guests just to start off by telling us about what you do. So tell us about Duke University Health System and your role there.
So the Duke University Health System is located here in Durham, North Carolina, in what is known as the Triangle, which used to be the Science Triangle, created between Durham, Chapel Hill, and Raleigh. And we serve about 12% of the population of North Carolina. Our aim is to grow and serve more of the residents in need of our services in North Carolina. As of right now, we've got 4 acute care hospitals, 3 here in the local region and 1 at Lake Norman, which is just north of Charlotte. And we have about 150 odd ambulatory clinics throughout the region, as well as home care and hospice and home infusion. We've got a staff of about 28,000 people, of which about 12,000 of them are nursing and patient care services staff. And I get the pleasure of leading that group of incredible individuals. And, every day is different in healthcare right now. And I would say the biggest challenges that I'm grappling with on a daily basis is how we keep the workforce we have engaged, because no matter where you are in the world, we're dealing with a shrinking workforce, how we continue to care for an aging population, and how we effectively integrate technology and innovation into the work we do to design the models of care for the future. So just a little tidbit of what I do on a day-to-day basis.
Yeah, I just read a statistic the other day where it said that recently the ratio of people out there working to people over 65 and on Medicare was 4-1. That's what it's been running at historically. 4 workers who are paying taxes that pay for Medicare Part A that is then used to treat the over 65s. And that ratio has gone from 4 workers to every Medicare enrollee to now it's 2.8. So the staffing challenge is real on a bunch of different levels. What are you seeing as the root causes of nursing retention?
I'm going to take us down a little bit of a path. At the beginning of the pandemic, we had a workforce that was stable. We had predicted shortages coming at some point in the future. And at the beginning of the pandemic, we saw everybody mobilize and band around and gather together and fight. And then we saw the images of the realities of what it was to care for an acutely ill population that was dealing with an incredibly difficult to manage, at least in the early days, respiratory viral illness. And then we saw the fatigue set in, and we saw the images of people leaving the profession and the great resignation and a lot of retirements. And basically what happened is we accelerated the path to what we knew was coming. Fast forward to today, we have a workforce of mostly new nurses. We've trained a whole bunch of new nurses over the last 5 years. A lot of our senior nurses have gone into retirement or transitioned into different careers. The struggle we have right now is making sure that the nurses that are new to our profession in the first 3 years, that they feel supported, that they stay engaged, and they keep their jobs. Our overall turnover is about 14.9%, which is kind of where it was pre-pandemic. But if you look at that 0 to 3 nursing population, it's up in the 20s. So how do we communicate, keep them engaged, keep them interested, continue to challenge them in ways that are positive and therapeutic and not detrimental?
So do you think you've seen the average age of your staff increase, or is it decreased? Because you've got the retiree population, maybe early retiring, so they're dropping out, but then you've got these younger coming in that are turning over faster and maybe going to different careers or whatever. So what do you think the average age has gone to?
Right now, the bulk of our nursing workforce is young millennial to Gen
Mm.
Z. So they are on the younger side.
Are you using technology then to help them do their jobs, maybe engage them more, given that that's the demographic?
Well, we're using technology in a number of ways. I would say communication, podcasts, text, social media. That's how this generation wants to communicate. But in doing their jobs, they also want access to technology and not to be burdened by it. And what I mean by that is we still spend a lot of time in the electronic health record documenting, and where we're seeing a lot of potential for shift away from that is with ambient voice recognition. Imagine a world where a nurse walks into a room with their iPhone. The iPhone picks up the entire encounter. It goes right into the electronic health record. We're starting to adopt those technologies. We've already started to see it adopted in the clinic setting with physicians, nurse practitioners, PAs, nurses in the ambulatory clinic setting, and now we're starting to roll it out in the acute setting. That's huge for our nursing workforce. And what's coming is really fascinating. At Duke, we're about to stand up 3 what we call innovation units. Basically, 3 tired old acute hospital units, 30 beds each, that needed to be rehabbed. So when we went in and did the refurbishment of these units, we partnered with some industry partners and we're outfitting them with new innovative technology that brings computer vision, electronic whiteboards, better ways for patients to communicate, ways for us to monitor patients and really shift away from that nurse that's reacting to bells and alarms, but gets data and allows them to be more proactive with the care. That's what our nursing workforce is looking for and getting excited about.
So I assume that's early stages of that sort of technology. Have you thought about how fast that's going to roll? Like, where do you think we'll be 5 years? I mean, is that going to be commonplace or
I think 5 years from now, a lot of that technology is going to be table stakes. The limiting factor is going to be our aging facilities. And how do we retrofit current acute care facilities with that technology? Right now, we do it with, rolling iPads and, we bring technology into the patient room. And I think as we have the opportunity to refurbish or create new facilities, that's when we will completely technology enable our environment.
do you see the older acute care facilities being retired and replaced by ambulatory type settings that are retrofitted with this stuff?
Yes, and in our world, what we see in the hospital right now was likely 10, 15 years ago in the ICU. And what we see in the hospital today, 5 years from now, is likely going to be more in the home or in a setting closer to the home.
Mm.
To be in a hospital, you're gonna have to be really, really, really sick, and that will require a different type of technology and enablement. But I think a lot of the patients that we care for in the inpatient setting are gonna go to the community in their homes. We started with the hospital at home program at the end of the pandemic. CMS launched that program, but now we've got technology that's really going to enable us to be more interactive with our patients in a real-time basis. We've got remote patient monitoring. We've got the ability now to communicate with patients in real time. I recently had the pleasure of going to Singapore and seeing some of their public health work that they're doing and how they're leveraging technology and wearables to reduce rates of chronic disease in the community, reduction in diabetes, reduction in hypertension, because nurses and docs are receiving information and in real time communicating with patients and making lifestyle adjustments and adjustments to medications. I see that as being our future as well.
But there you got another player that you've introduced to the technology, which is the patient themselves.
Right.
So what does that patient then look like? Are they wearing something? Is there something placed in the room that's just able to monitor them and pick it up without any catheters or anything going into the patient? What does the patient have to do?
Well, that's evolving too. It's fascinating. So many of us have wearables now. This is an Aura ring, and I've got an Apple Watch as well. We're already engaging in wearable technology, and there's more data that is being collected and can be collected, and the technology is evolving. So I think we are going to a world where it will be a watch, a simple wearable, a ring, maybe a glucose monitor, although again, the technology is transforming so rapidly. The burden of devices will actually decrease, but the capability of the small focus devices that become normal for us are going to expand exponentially. And if you think about care in the home, and this is going to sound a little out of this world, but it's actually in development. In the UK, they're already starting to think about humanoid robotics in a home health setting. A patient who's at risk for fall, a patient who needs assistance, may not have family there available in the close vicinity. How are we going to be integrating those things as well?
Yeah, that's interesting because there's a point where you've got people who that will work for because they are might be older or even younger patients, but I'm thinking of the older patients who are, quite frankly, up for the game, right? They're okay. I'll wear it. I'll do it. But then you've got this whole other population of patients that just have no. They're not technology people, and they're not even figure it out for themselves people, right? They're just, I don't know how to do this. I just give me a nurse here full time. So that I see that as an issue. Are there things out there trying to solve the issue for those folks as well that you're seeing yet?
Yes, and you're right. It's a huge issue, and I think that's where we default to more telephone engagement, check-ins, and really using a hybrid approach with someone who can go visit the home and help the patient collect data in real time, give that patient face time, interact with the patient, but also be able to work with a clinician that's remote to make changes in real time for that patient. You're right. There are just some patients who it's not what they were ever brought up with. It's not what they're used to. It's not what they're comfortable with. And meeting their needs means marrying the human touch with all of the other technology and helping make that human in the moment provide the most value add care they can with the skill set they have, but also allow them to be more efficient with more data and support in the background with the use and enablement of technology.
So we get the technology right. We've still got the most important part, which is the people, the nursing population, the PAs, the physicians that have to deal with this and have to work with it as well.
This episode is brought to you by the Center for Healthcare Leadership and Management, the definitive resource for healthcare management education in North Texas. The center is based in the Naveen Jindal School of Management at the University of Texas at Dallas. It plays a unique role in training the next generation of healthcare leaders to meet local, regional, and national demands. The Jindal School uses its strengths in accounting, administration, finance, marketing, and information systems to educate highly qualified personnel for healthcare administration and executive leadership positions. The center is home to 7 healthcare leadership and management programs, including undergraduate and graduate programs, as well as executive programs for physicians and working professionals. For more information, visit us online at jindal.utdallas.edu/healthcare.
So are you using AI or any other type of technology in your workflow management today? And if so, how do you see that changing and morphing into this new paradigm we're looking at?
Well, I think it's getting back to the meeting the needs of the workforce. So yes, we are using technology. We've got a workforce that has different needs from their employer. Is it a 12-hour? Is it 3 12s? Is it 8s and 4s? Is it I need to pick up shifts when I can? So really managing the workforce, the logistics of our people. We're using AI and technology to help with the management of our people logistics. And then decision support, research. Used to be if I wanted to research a particular condition that I had to go and do back in the way, way back machine, I had to go to the medical library, and then there was Dr. Google. But now we've got large language models, and there are specific AI tools that are geared for medical professionals that come from highly respected, validated sources that allow me as a clinician or a nurse at the bedside to research something very quickly, to then allow me to have the information I need to make the best clinical decision I can for that patient in the moment.
And that raises the question of how do you train your nursing staff to use that technology, and do you have standards within your organization around using AI or policies around using AI? Like how does an AI tool get to be a tool that is used, officially in your business, in your particular organization?
Well, Duke actually, together with UCLA, kind of led the charge on that with developing the ethical use of AI model. So any new tool, any new technology that we introduce, we look at it from the perspective of efficacy, ethics, usage, making sure that we're using the right tools in the right setting in the right way. The training, that too is evolving. How we train our workforce of the future is evolving. In fact, we're just now on the School of Nursing side looking at how we embed utilization of AI and new technology into our workforce preparation. These are things that, if you think back, academics did not endorse the use of Google to do a literature review. Now we have large language model ChatGPT where I can go in, put in a few prompts, and get tons of peer-reviewed articles. We're now starting to warm up to that and adopt that, where there was a really hard line traditionally into not losing our keen skills to conduct research. But now those skills need to change and evolve.
Is it fairly open to a leader like you to use whatever tools you deem acceptable for your team, or is there a higher level type approval process that before we use any type of large language model or any other type of AI, it has to be signed off by this group or that group?
We actually do have a group that reviews our adopted technologies in the Duke Health system. And that's all part of that model around ethical use of AI.
Mhm.
We want to make sure the tools we use are safe, are validated, and that they're going to support our staff and our clinicians to be the best caregivers they can be for their patients. And we also want to mitigate risk. So the tools we use do go through a fairly rigorous vetting process.
Are the staff overall accepting the use of tools like that? Are they scared off at all by it just because of the negative publicity that's been out there around AI and how it can give you the wrong answers? Or is it, are they accepting it, or are they afraid of it, or is it somewhere in between?
It's somewhere in between. They're evolving. They're absolutely evolving. And you always have that adoption curve, right? They're the early adopters. They're the ones, that big bell curve in the middle of the people who are just kind of feeling it out. And then there are the people who really, no matter what you do, they're always going to be skeptical. I would say we're seeing more adoption as we're becoming used to these things, but it's coming so rapidly.
Yeah, I think once they start to use it and realize the benefit of it, and then start to be able to trust it, then I think that it'll be adopted. At least the large language model part of the AI will be adopted fairly quick. I know I've done stuff on my own just for my own research purposes where I actually knew the answer to what I was researching, but I needed to document it, right? And I needed to get the whatever the code sections are, or whatever I was looking for. It would have taken me forever to go back and figure out, okay, I know the answer, but how do I document where I got there? And I put it into a large language model, and son of a gun, I mean, complicated things. It pops up with the answer in 15 seconds, and it points me exactly to where I needed to go to get, information I needed to document it. So I think it'll start to be used like that. The more often AI is right, I guess the less often it's wrong. It'll become to be accepted, especially by a younger workforce.
Mhm.
Like you're dealing with. So any other solutions that you have in your organization at Duke University where you're using either advanced technology or AI to treat patients or monitor patients? Like, do you guys have a virtual care center type of a location where you've got offsite monitoring?
We do. We have something called the Virtual Care Center that was stood up during the pandemic. And right now we've got two fairly significant bodies of work that are managed through that virtual care center. One is something called remote safety observation, where we've got, again, I talked about those iPads that you roll into the room for the rooms that aren't tech enabled, where we can roll an iPad that is loaded with technology that uses algorithms to detect when patients may be at risk of getting out of bed. And the thing that we're trying to mitigate there is falls. Falls are one of those 5 harms that happen in hospitals that can be extraordinarily harmful for patients. And so we have that technology enabled. Back at the remote safety observation center, we can have one person monitoring a handful of patients on screens, and the tech gives them a warning when a patient may be making movements that shows that they are likely at risk of trying to get out of bed. That observer can then call the nurse on the floor, and the nurse can go and respond. So that's one body of work where we're really trying to make sure that we're doing everything we can to mitigate falls risk. And then the other group that we've got in that virtual care center is our virtual nursing unit. So we talked about the older nurses, the nurses who were maybe heading towards retirement. And we offer those nurses the opportunity to work in the virtual care center. They're experienced nurses. They've got breadth and depth of experience, but maybe the bedside is too physically demanding.
Mm-hmm.
So those nurses can then augment the on the floor workforce and help with patient and family education, admissions, discharges, coordinating medications, while the nurse on the floor can be responding to a number of different patients' physical needs. But this virtual nurse can, again, be brought right into the room on the iPad, or when we've got the tech enablement, be up on the video screen talking to the patient and family.
And so is that virtual care center nurse monitoring for the fall risk, but also are they able to see other vital signs and monitor those as well?
Not quite. Right now, that technology is somewhat rudimentary, and I call it rudimentary, although we're using fairly advanced algorithms for the remote safety observation. But what we haven't brought in is the wearable technology for the vital sign monitoring in real time. Now, the virtual nurse, on the other hand, so these are two distinct teams. So we've got the remote safety observation unit. They're monitoring for falls. But then the virtual nurses are in the medical record, and they can see the most recent vital signs and all of that information as they're preparing the patient for discharge.
Mhm.
They know what the most recent vital signs, pain scores, all of that information. They've got it all there.
Right. Well, I don't want to let you go without asking again back to the workforce retention issue or building the workforce of the future. We had a podcast episode a few months ago related to a high school in Houston that is, being stood up by Bloomberg or with Bloomberg's investment. That's basically a healthcare high school. Are you seeing that type of activity in your area where they're actually trying to build the workforce before they even get to the nursing school level?
We too were recipients of a Bloomberg grant.
Oh, there
So
you go.
Duke Health received a $29 million grant from the Bloomberg Foundation. And we are establishing the Durham Early College High School program together with our partners in the Durham Public Schools and Durham Technical Community College. And our first class of 100 students, these are kids that are, they're 8th grade graduates who are entering high school, but they're going to enter this early college high school program. And they choose a pathway: nursing, medical assistant, pharmacy tech, and research. They can choose one of those 4 pathways. And at the end of 4 years, actually it's 4.5 years, they will have done observation training in the health system. And they will graduate with a certification, or in the nursing pathway, they'll graduate with an LPN. And we're ready to employ them on the health system side. It's been phenomenal standing up this program together with our partners. And it was great seeing the excitement in our community for the first class. We did an event where the first group of kids and their parents all came together. And it was just wonderful to see the excitement. And how great is it that we get to do this with our community, but also start to build our workforce really early on.
Yeah, I mean, it's fascinating. You hear the doom and gloom out there a lot about how the over 65 population is growing and it's going to outgrow the care team's size that's going to be willing to be able to take care of it. Oh, gloom and doom. But you don't hear enough about, but there are actually people thinking about the root cause of the problem and going after it even before these students get to high school, trying to rebuild the population of healthcare providers of the future. It's really interesting to see that you're right in the same place that they were in Durham. And I saw a high school it's actually connected to one of the hospitals up in Cleveland. Their safety net hospital actually has a high school that's actually in the same building. It's connected to it. So these things are out there in motion. So don't underestimate the minds of the folks who are actually trying to solve this issue.
Oh, absolutely. And interestingly, a fun statistic, we've actually seen an increase in nursing school applications.
Oh, that's fantastic. Yeah. Well, Terry, thank you so much for being with us. It's fascinating. We know that Duke is on the forefront of these issues, and we are very fortunate to have you be able to come on and share what you guys are doing.
It's been such a pleasure. Thank you so much.
Thanks for listening to the Business of Healthcare podcast. To learn more about the Center for Healthcare Leadership and Management and the healthcare management business degrees and certificates available to seasoned clinicians, master's students, and undergrads through the University of Texas at Dallas, go to jindal.utdallas.edu/healthcare.